Good evening, ladies and gentlemen. I am Indrani Malkani, Chairman and Managing Trustee of V Citizens Action Network. On the eve of World Stroke Day, I extend a warm welcome to all of you to our social sanchar on brain attack or strokes. During these uncertain times of COVID-19, many anxious questions comes to our mind with respect to our health. With this in mind, we decided to expand our social culture series with a new one on health and well-being, featuring leading doctors and healthcare professionals as our speakers. Of course, our regular social sanchars will also continue when the gatherings will be permitted. Strokes are becoming an increasingly important cause of premature death and disability in many countries, including India. Majority of stroke survivors continue to live with disabilities, and the cost of ongoing rehabilitation and long-term care are largely undertaken by the family members, which then impoverish them a great deal. Sadly, there is a great lack of awareness about strokes. So that was the intention as to why we figured that it is high time that this subject is taken up and discussed. Before we begin, we'd like to tell you a little bit about ourselves. VCAN is a registered public trust, and our overarching objective is to establish linkages between the government and the citizens, and we work in partnership with several government authorities. Our focus areas include aspects of health, air pollution, road safety, fire safety, waste management, electoral processes, among others. We are a non-political, not-for-profit organization, and all donations are exempt under Section 80G of the Income Tax Act. Recognizing some of the basic challenges that citizens in urban areas, primarily in urban areas, face, we set out to have a web portal, interactive web portal, www.TogetherVCAN.in, which deals with multiple challenges on a single platform. In order to make things much easier for citizens, we started our interactive talk show series, Together We Can's Social Sanchar, with the motto, interact with your government from wherever you are. And now with a new series, we get eminent doctors to discuss the issues with respect to health, which is very crucial to all of us. I would like to, at this point, particularly thank our support partner, the Bridge Candy Hospital Trust, which has supported this evening's social sanchar. I thank Team Technolegion for powering this version of our social sanchar and for always being vigilant and keeping our web portal going. I also thank Mr. Sumit Lula, and I am delighted to specifically thank the Jai Hind College Student Council and all the students of the college, Jai Hind, which is our college partner, and all the other colleges who have associated with us. I thank our friends in the media and all of you for joining us today. We have about 86 colleges which have participated for this social sanchar. We will be uploading the list of colleges on our portal, so excuse us if we are not able to show all the names just now. I was hoping that Mr. Ranganathan, our fellow trustee and former municipal commissioner, and who has also set up the state of Maharashtra, to introduce Dr. Karapurkar, but it appears that his line has got disconnected, and I'm sure that he will join us shortly. Dr. Karapurkar is an interventional. Mr. Ranganathan is just joining, but we have Dr. Karapurkar already with us. He is an interventional neurosurgeon and is a senior consultant with the Breach Candy Hospital and indeed with other hospitals as well. Dr. Karapurkar's profile will be uploaded also on our portal. Mr. Ranganathan, thank you for joining us. Will you please introduce Dr. Karapurkar to our viewers?
I'm really happy to introduce Dr. Anil Karapurkar. After doing MBBS, he did two masters, MS in surgery and second MS in neurosurgery. And thereafter, he had special training in neurovascular intervention in France. And starting with KM Hospital, now at present he is a senior consultant and Breach Candy Hospital. And he is also a teacher in a new branch of medicine, neurovascular intervention. He has distinguished himself as the president of the Indian Society of Neurovascular Intervention. He has also been president of the International Asian Society of Asian Federation of Neurovascular Intervention and member of the World Governing Body of Neurovascular Intervention. We are indeed fortunate to have an eminent person of this to help the kind of the fear which people have. Suddenly you have a stroke or what people often call a paralytic stroke, and you find that all of a sudden you get disabled for life. So we do look forward to his guidance, how to prevent the occurrence of events, and what do you do if unfortunately you get caught up in such a situation. With these words, I would request Dr. Anil Karapurkar to start his presentation, which will be followed by a discussion and question answer session. Welcome, Dr. Karapurkar.
Yes. Dr. Karap, I would like to also share with the viewers that we have received quite a few questions and a few case studies as well. Now, being a public forum, we will not be able to give the names of the people who have shared their case history, but I have on pass to Dr. Karapurkar, and he will address in a general way through his presentation all the issues that have been highlighted to us. Dr. Karapurkar, please do share with us, all the lay persons who are watching also, and some who are patients, what are the causes of the stroke, what types of strokes, can we recover from a stroke, and in COVID times, is COVID also a factor for strokes, and or how do we deal with it should a person be so unfortunate to have a stroke at this time, and many more. Please enlighten us on this issue. And it's very fortunate that tomorrow is World Stroke Day. Dr. Karapurkar.
Thank you, Indrani. Thank you, Mr. Ranganathan. It gives me great pleasure to be a part of this World Stroke Day celebrations. We are on the eve of the World Stroke Day, and it's a very appropriate time. There is an abysmal, Indrani mentioned, but it's abysmal, the ignorance about stroke. Everyone knows about the heart, but about the stroke, very little is known. May I have the slides, please? First is, what is a stroke? Let's start with that. Stroke is where there is a sudden loss of function of a part of the body. It may be any part of the body. Next slide, please. So there is a sudden loss of function, and depending on which part of the brain is affected, the patient will get symptoms accordingly. So it may be vertigo or chakkar, it may be loss of vision, it may be paralysis of one hand or just one finger. It just may be the index finger that may be paralyzed. Or sometimes there is severe headache, vomiting, or even convulsions. And in fact, a lot of our patients are found in the bathroom. And I always tell that if a patient falls in the bathroom, it's very difficult to get the patient out of the bathroom because the doors often open inwards. Even in hospitals, I've seen this, surprisingly. So if a door opens inwards, the patient's body stops the door from opening and you can't get the patient out. It's quite difficult. So all doors from bathroom should open outwards, not inwards towards the bathroom. And now in Mumbai with small houses, you have to use as much space as you can. So we have to tell the builders, open the doors outwards, not inwards. Next slide, please. Next slide, please. Yeah. So it's a semi second, no, one before that. For some reason, I am not able to control the presentation myself. It is being controlled from the back end, and therefore I'm asking the Mr. Prasenji to advance the slides. So bear with us, please. So it's the second most common cause of death. This has been recently found in a multi-center study which was carried out from All India Institute of Delhi. And you can see the prevalence. It is 2.2. India, we have a lot of patients with a population of 1.3 crores. You can imagine 2.2 per thousand population. And as we grow older, when we reach 55 to 65, it is 7 per thousand. And now life expectancy being more than 65, the incidence will be much higher. What we have to remember is stroke is lethal. 40% die after a major stroke. 30% are totally dependent. They need full support. And more than 50% do not go back to their previous work, whatever it was. So it's a huge social problem. Next slide, please. So this is a picture of the brain. Let me just show you some anatomy. So this cerebrum is the main brain, the front brain. We call it the forebrain. The cerebellum, which is below, is triangular in shape, and the two are connected by the bridge pons, also called the brainstem. Brainstem consists of three parts. So the right half of the cerebrum controls the left half of the body, and the left half of the cerebrum controls the right half of the body. The cerebellum, the right controls the right, the left controls the left. And the two halves, the cerebrum and the cerebellum, are connected by the pons. And so if there is a stroke, one more thing, if one person, most of us are right-handed. So in a right-handed person, the area of the brain with which we speak is on the left side. If you are left-handed, many people are born left-handed, but they are made right-handers by their family members. So then it is confusing for us as doctors, which side is the dominant hemisphere. Is the left side which is dominant, is the right side which is dominant. So then we have to do special tests to know with the dominance, which side is the dominant one. Next slide, please. So this slide will show which parts of the brain. See, what is marked in red is what we call the motor strip. So the leg area is relatively small. The face and the arm area is always big because the face is a very mobile and we have hundreds of muscles in the face. So we need a big area of representation in the brain. So the red is motor, the blue is sensory. If I touch my index finger, the impulse will pass from my index finger to that blue area. And as you see, leg, arm, trunk, it is in the represented inverse. The face is at the bottom, the leg is at the top. The blue area in the one which you see from the side, the violet area, that is the part of the brain with which we see. The impulse passes through the eye to the brain. So that is called the occipital lobe. That is the visual cortex with which we see. Next slide, please. So we need to know the structure of the brain. So remember, if there is a paralysis on the left side, if it is cerebral, the stroke is on the right side. If it is cerebellar, it is on the left side. And the brain circulation is also a wonder of nature. There are two major arteries. The big ones on the two sides are called the carotid arteries. The two in the middle join to form a single artery called the basilar artery. We call that the posterior circulation. The big arteries are the anterior circulation. And there is a cross communication between all of them. The picture shows it beautifully. You can see the front artery joining with the back artery and the right joining with the left on both sides. Though it is showed like this, it is very unusual to have a complete circle. We call it a circle of Willis. So the circle of Willis is more often than not incomplete. One of the arms of that circle will be missing, but the brain always compensates by getting blood from somewhere else. And on the side is the blood supply of the spinal cord, which is also very complex. Today we won't dwell on that. Next slide, please. So, what is brain attack? I told you it's a loss of function of the body. It is always sudden, out of the blue. You are perfectly all right. Seconds later, you have this. If it is in the anterior circulation, the carotid territory, as I told you, cerebral hemisphere, there is loss of vision, there may be weakness of the arm, leg. So there is now an acronym, face, arm, speech, and time. Time is, I'll come to that in a minute. Posterior circulation is more complicated. In fact, posterior circulation sometimes can be missed even by neurologists. Strokes of the posterior circulation are difficult to diagnose because there is a variety of symptoms which can happen. Vertigo, blurred vision, imbalance. If it is carotid territory, it will be loss of vision in one eye. If it is the posterior circulation, it will be both eyes. Because if you remember, the two front and the back are connected by the brainstem. So it's the brainstem which is maximally affected, and the brainstem controls both sides of the body. In hemorrhage, there will be severe headache and vomiting or convulsions. Next slide, please. So strokes, that is our bane. Stroke is of two types. One is called ischemic, which is loss of blood supply, and the other is hemorrhage, where there is rupture of a blood vessel and hemorrhage into the brain. So if there is loss of blood supply, it is completely different treatment. We have to open the artery. So we give a blood thinner. If a patient who has a hemorrhage, you give a blood thinner, the patient will die because the hemorrhage will just continue. Next slide, please. So today we are going to talk essentially about ischemic stroke. In fact, for ischemic stroke, we had little to offer. And there was a nihilistic attitude, even amongst doctors. You got a posterior circulation stroke or you got a major stroke, you're doomed. You know the recovery. But that's not so today. Since 2015, we have changed. And therefore, there is a stress now that we try and do something as early as possible. So what are the causes of ischemic stroke? The most common cause is a blockage of the artery in the neck, just as you get in the heart, or a clot going from the heart into the brain. There can also be what we call dissection or tear of the artery, and that can cause an occlusion of the artery. So these are the basic causes of stroke. Either the artery in the neck or along its course inside the head gets narrowed and blocked, or a clot goes from the heart. Next slide, please. Hemorrhage, on the other hand, is different. The vessel has torn. The most common cause is high blood pressure. We'll talk in detail about hemorrhage at another time. I will request Indrani that we have a second session where we talk about hemorrhage, because it's impossible to cover the whole subject of stroke. As you can imagine, I'm starting with anatomy, and I have to get to the nitty-gritty of what is stroke. So there are various causes for hemorrhage, but suffice it to say that high blood pressure, uncontrolled high blood pressure, is the most common cause. There are various malformations of blood vessels called aneurysms, which are like blisters. That's a huge aneurysm that you can see on one artery. The artery just expands, blows out into a balloon. And there are AVM, arteriovenous malformation, which is a bunch of blood vessels. Sometimes tumors can be very bloody and they can bleed. Or there are various other causes. So next, go to the next slide, please. There is a big difference between heart and stroke. I get very upset. Half of our patients first go to a cardiologist and then come to us. They waste time. Heart has only one function. It's very simple. It's a simple organ. It has muscle, nothing else. One function, pump blood. Brain has various functions depending on which part of the brain is affected. If it is front, it is back, it is arm area, leg area, speech area, vision. So it's very difficult. Heart attack, only loss of blood supply. There is no hemorrhage. In the brain, we do not know whether it's a heart attack, which is, it is an ischemic attack. We call it ischemia. When there's loss of blood supply, we call it ischemic stroke. And the other we call a hemorrhagic stroke. So AIS is the short form, acute ischemic stroke and hemorrhagic stroke. So because we don't know whether a given stroke is hemorrhagic or ischemic, we cannot start treatment at home. For a heart attack, you can give aspirin at home. You can put a tablet under the tongue, the sorbitrate, and you can treat it, but not for the brain. For the brain, you have to go to the hospital to get some form of CT or MRI done. Without that, treatment cannot start. And what is again very important, even after a major heart attack, either the patient is dead or the patient lives and is able to look after himself. Even a minor stroke may leave a patient totally dependent. A small area of the brain, speech area gone, means your life is finished. So a minor stroke also can be very dangerous. That's why I am astonished. People take a chota sa stroke hai, kuch nahi hoga. That is very dangerous. You must treat every stroke as a major stroke because it can leave you totally dependent. Next slide, please. There are various types of stroke. TIA, transient ischemic attack. This is like your angina, where the patient gets a paralysis for a minute or two and he recovers. The definition says 24 hours. Recovery in 24 hours. But 24 hours is too long a time to wait. If a patient does not recover in 5 minutes, he should assume that this is a major stroke. So what do I mean by TIA? For instance, somebody is shaving, he drops a razor. He's brushing his teeth, the brush falls off. He's holding a cup of tea and the hand starts shaking or he's not able to hold it. This is a TIA. He recovers in 5 minutes, this is a TIA. If he doesn't recover, this is a stroke. So don't wait for it to recover. Think that this is a stroke right from the minute the trouble starts. So we have sometimes the patient has a TIA, he recovers, gets a second one after 4 hours, gets a third one after, and then he keeps getting paralyzed. So that's called stroke in progression. Or if a major artery gets blocked, patient gets a complete stroke right from the beginning, and that is bad. If a patient gets a complete stroke right from the beginning, that is bad. The chances of recovery are much less. So I always say, remember, TIA, transient ischemic attack, is a retrospective diagnosis. Don't think this is a TIA and you will recover. Assume that this is a stroke. Next slide, please. So, next slide. Why am I so insistent on time? Time is very important. Every minute that the brain loses blood supply, millions of brain cells die. And there is a plethora of types of cells. The brain cells also are not one type. There are multiple types of brain cells, and 1 minute of loss of blood supply means millions of cells are dead. And they are dead. They don't regenerate. It's not like the liver which will regenerate. The brain does not regenerate. Once it dies, it is dead. Some other part of the brain may take over that function, but the part which dies is dead. So we have to be very fast in what we do. So we have to get to the hospital, get a CT, get things, and we can give an intravenous injection, which is expensive in the first 3 hours. We can do a thrombectomy. We can pull the clot out for up to 9 hours. And there is something called bridging therapy, which is also done. Got a small hospital next to your house. They do a CT scan. They show that there is a stroke. They give the injection and then shift you to a major hospital. So that is called bridging therapy. Trip and shift. Next, please. So once the window is over, we cannot. No. Go to the previous one. Go to the previous one. Previous one. Previous one. Yeah. So we can only do this up to 8 hours. After 8 hours, there is no specific treatment. So one of the questions which I had today morning was that I had a stroke and the patient has not recovered. See, what we can do only in the first 8 hours. After that, it is the patient's luck. There are some patients who even with a very major stroke recover fully. There are some who do not recover. But it is for the patient to put in an effort. And again about recovery, the motor part recovers better. The motor is where you are moving your hand and leg. But sensation, we have no treatment for sensation. For motor recovery, we have physiotherapy. But for sensory recovery, there is nothing. And as Indrani said in her introduction, in India, patients, family, we have very little insurance. Most of us don't have insurance. And those who do have a very small amount. So spending on rehabilitation is very difficult. So in India, if acute treatment can be offered, that is ideal. Because if that window is gone, then you can't do anything. Then it is left to the patient. And some of them, I can tell you, are you have tears in your eyes when you see a patient who is paralyzed, who is fully conscious, is able to understand everything, but he cannot move his hands or legs. He cannot speak. He cannot swallow. He cannot pass urine. So these are something which are very very difficult to even imagine. And here there are families who look after their patients for ages. Next slide, please. So after 8 hours, all we can do is nursing care and medical therapy to prevent complications. Next slide. So therefore, what should we do? If a patient gets what looks like a TI or a stroke, don't waste time. Inform a hospital, ideally a stroke ready hospital. We call it a stroke ready hospital where CT or MRI can be done. Go as quickly as possible. Call and inform the hospital stroke patient is coming. Don't go to a GP. Go straight to the hospital because the GP will come, he will do something, waste time. So go to a hospital where insist on a CT scan or an MRI scan. Don't I would say don't waste time. Go to a or go even to a standalone center. Go to a hospital where once the stroke is shown, treatment can be started. In fact, we start treatment on the CT scan or MRI scan table. Next slide, please. So go to a hospital where CT scan or MRI can be. And in the hospital, what is done is the stroke team is activated. If it is a stroke ready hospital, there is a stroke team. So they come and do a quick neurological examination. We have a standard worldwide scoring system, which is called the NINDS score system, NIHS score system. So we quickly do an examination. We collect the blood. If the sugar is more than 400, we start insulin. If it is very low, because even low sugar can cause a stroke. So low sugar we correct by giving sugar or glucose injection. This is another thing. Whenever there is a stroke, whether it is hemorrhagic or ischemic, the blood pressure rises. Even in a normal tensive person, a person who's never had blood pressure, the BP may rise. Don't treat that BP because that is what is maintaining the blood flow to the brain. Unless the BP is more than 200, we don't treat the blood pressure. Leave it floating at 160, 170, 180, 190. Don't treat unless it is more than 200. This is for the general practitioners also or for specialists. Don't treat the BP unless it is more than 200. And as quickly as possible, shift the patient for CT or MR and insist on CT angiography or MR angiography. Next slide, please. CT scan shows hemorrhage very well, but it does not show ischemic stroke as well. And I have patients who have had normal scan. अरे इसका normal है कोई घबराने की बात नहीं है. In fact, it is more dangerous. If there is a big infarct, the scan is normal. The patient is still paralyzed. In fact, this is sinister. This is dangerous. So patient should be intervened early. Next slide. Next. Okay. Next slide. I should have come here first. So this CT scan shows hemorrhage. See these white shadows that you see. So the third slide in the upper row is intracerebral. That's the brain bleed. The others are, I think one of the gentlemen had shown the picture that I don't have a similar picture here. Anyway, so these are white shadows are hemorrhage. You see this very well on a CT. You don't see this as well on an MRI. Next. But you see this next. Next slide, please. So you see this CT. The CT scan is normal on the left. This is within a few hours of the stroke. The one on the right is done next day. And now you can see this big black area. That big black area in the brain. The other black area is containing the what are called hydrocephalus, called ventricles. The big black area in the brain is a stroke. So the first scan is normal. You begin to see the infarct. We call this infarct after 48 or 72 hours on a CT scan. Next. But on an MRI, next slide please. On an MRI scan, even a small infarct, a tiny infarct can be beautifully seen. So here, this white area corresponds to this black area. So if you have both these, this is an infarct and nothing else but an infarct. So this is called an infarct, which has no blood supply. So there are two parts here. So it means two arteries are blocked. A clot from below has gone up and blocked two arteries. So we don't bother about the arteries. What we have to see is what it has done to the brain. Next slide, please. So this is an angio. This is a CT angio. You can see a big artery on the left side. On the right side, you see an artery up to the skull base of the skull. Beyond that, it is very faintly seen, and then again inside the head it is seen. So there is a big clot which is sitting inside this artery which you see faintly. So this is what we want to see on a CTA or an MRA. Why? Next slide, please. Why do we have this window? We have this window, next please, because if we are late, there will be hemorrhage. So what are the contraindications for treatment? Immediate treatment, hemorrhage, beyond the window period. Initially, we used to say 9 hours, but now we have got certain criteria. We have extended this to 18 hours. But beyond 18 hours, nobody has tried to do anything so far. Age, below 18 and above 18. Why exclude children? The youngest child I have treated is a 6-year-old. In fact, age is no more a criteria for contraindication because we have treated 90-year-old. 94-year-old is the oldest that we have treated. But a large stroke, if it is a very big artery, that is an absolute contraindication for us. Because there is a very high risk that what was an infarct, no blood supply, now gets a hemorrhage. So we call it a pale infarct, becoming a red infarct, getting hemorrhage. Hemorrhage is blood, right? Red blood. Next slide, please. So I told you the injection is 1 to 3 hours. The intravenous injection, that is called acrylize or altiplase, and the other is tenecteplase. This tenecteplase is a new drug which has been approved by the government of India. It is almost a third of the cost of altiplase, and it is more effective, and you need a smaller dose. In India, it has been approved. It has not been approved in the rest of the world. Tenecteplase. This is also used for the heart. It's the same drug which is used for what we call IV thrombolysis, intravenous thrombolysis, and it can be very effective. But if it is a large vessel occlusion, if a big artery is blocked, big pipe is blocked, an injection given intravenously does not work. So you have to go to the clot and remove the clot. Next slide, please. So to remove the clot, we call it large vessel occlusion, which is seen on CT angio or MR angio. Now, this is another thing I have seen. Many neurologists, physicians ask for an MRI or a CT. If you are suspecting a stroke, why ask for an MRI or CT? You already know the diagnosis. You are suspecting a stroke. Ask for an A, because that will show the site of the infarct, the size of the infarct, like I showed you on the MRI, and it shows you cause of the infarct. So if it's a big vessel, an intravenous injection will not be sufficient. You will need to pull that clot out. So you should be prepared, get the cath lab ready to do the thrombectomy, as we call it. We call it thrombectomy. We actually pull the clot out. And this has happened since 2015. Before 2015, we were not imaging the main artery. After 2015, there were 5 major studies. All of them showed that if you image the artery, open the blocked artery, the outcome is so good. 60% of our patients recover very well. We call it MRS grade 0 to 1. They are very good. They are almost normal. So we have to do MRA. Next, please. So to extract the clot, to do the thrombectomy, we have two techniques. One is where we suck the clot out. Next, please. I don't know whether this video will work. Next, please. So we have 2 techniques. One where we suck the clot out, and the other is where we remove it with a stent. So today with these devices, we can open an artery in 15 minutes. So in stroke ready hospitals, they try and time the procedure. The time is recorded at which the patient arrived at the door of the hospital, from the door to the casualty, from the casualty to CT or MR, from the CT or MR to injection needle, so CT to needle, If patient needs to go to the cath lab, CT to groin, and groin to recanalization. And all of these are maintained by the hospital, and they have to show that progressively they are doing things faster. Only then do they get stroke recognized. This is true in Europe and America. The big difference in Europe and America is in Europe, for instance, in France or in Germany or in England, if a patient gets a stroke, the hospital doctor decides what to do. The family has no say unless the patient has written down. Nothing that the family says is observed. It is decided by the doctor what to do. Of course, our major problem is payment. In Europe, the payment is made by the government. They don't have to bother about where the money will come from. For us, every single paisa is important. So for us, one of our major problems is the cost of what we do. CT is very cheap. MR is more expensive. MR is also more time consuming. But MR gives us much more information. I, for instance, personally am very happy with an MR. So if you are a stroke ready hospital, you have an MR protocol. So the MRI is done in 13 minutes, 13 minutes. Normally it takes 45 minutes to do an MRI. But for stroke, we do it in 13 minutes. CT scan takes 2 minutes. It's even faster. But most hospitals world over rely on CT and they do an MR only in specific instances. But MR is very useful. So it shows you the artery and it shows you where the size, site, and cause of the infarct. All of these things. So as I said, 2015 onwards, we've got a complete change. And now we are doing more and more. In Europe, any hospital which was doing 5 or 10 in a year is now doing 300 to 400 cases in a year, which means they are salvaging 300 to 400 patients. They are returning 300 to 400 patients to society every year. In India, even major people like us, we are doing hardly one in a week or 1 in 2 weeks, which is ridiculous. And we should be doing one every 3 or 4 every day. The number of people we have, our population. Mumbai alone has such a huge population. Next slide, please. So I said we can recanalize the artery in 15 minutes. So actually, our neuro labs are different from the cardiac cath lab. This is a true neuro lab. This is not a cath lab. This is a neuro lab. Here there are two tubes. We see at the same time in two planes, from the front and from the side. So we can see from two planes what we are doing. So it makes us do things much faster. We can do, because we can see in two planes at the same time, we do everything much faster. So here time is of essence. We have to be as fast as possible so we can recanalize the artery in 10 minutes. Unfortunately, Mumbai, we have failed to convince our hospitals to buy. So in the private sector, for instance, we have only two biplane labs. Luckily the municipal hospitals, the Nayar and KM, the new Hindu Hruday Samrat Balasaheb Thackeray Hospital, 4 of them have got biplane labs. JJ Hospital has got one, but in the private sector only 2. In Delhi, there are about 10 in the private sector. In Chennai, there are about 7 or 8. Bangalore is 4 or 5. But Mumbai, the capital of finance, we've got only 2, which is ridiculous, absolutely. Because makes it so safe and much faster. No question, we need a biplane lab. I don't have one. Next, please. I'm working on a monoplane lab. Next, please. So this is the aspiration technique. I don't know whether the video will work. Prasenjit, do you think it will work? Otherwise, we'll go on to the next one.
Yeah, go to the next.
Okay. So this is about extraction only, thrombectomy. We pull the clot out. So this is the network of the blood vessels. You can see this artery. You can see a wire coming up, and on that wire we are bringing up a catheter. This is a very delicate wire. So we come to, you see that block in the artery. We cross that block with a wire. This is a very delicate wire. It does not injure the artery. And the flow goes through the clot because the clot is like jelly. It's exactly like jelly. It goes through easily. So then we bring this catheter up. This is a very tiny, again, it's called a micro catheter. So we bring that catheter and we do it under vision. We don't do it blind. The cardiologists work blind. We do everything under vision. We have a special technique called roadmap. I can't show you that because the videos won't work. But so all of this, what you're seeing now, this is an animation, but we actually see it exactly like this on the screen. So we have now got the microcatheter across. Then we will bring the stent. Now this is a special stent meant to remove clots. So this is a thrombectomy stent. This is not like a cardiac stent. These are completely different. These are what we call self-expanding. They are inside that tube. When we pull the tube back, the stent opens out. We pull the tube back, the stent opens out. It stays there. We wait for about a minute or so. We have this big catheter in the neck. So there we have a balloon on the tip of the catheter. We inflate that balloon. We block the flow. Now there is no more blood flow. And that clot gets trapped in that mesh, the stent. And then we pull the stent which is open all the way back. Oh, it went off, I think. What happened? No, we went to the next slide. Anyway, so that whole stent gets pulled back, and then we can go on to the next slide. So this is how we show what has happened. If you see the first image, there is a complete cutoff. There is no flow beyond. So that is called sticky thrombectomy in thrombectomy in cerebral infarction. So the artery shows a complete cutoff. In the second one, there is a thin trickle of contrast of medicine going past. In the third one, there is some filling, but there are large areas where there is no blood flow. So we call that sticky 2 or 2A or 2B, and 3 where we've restored the complete circulation. So when we are treating these patients, we always aim for sticky 2B or sticky 3. We call it sticky thrombolysis in cerebral infarction. The cardiologists call it TIMI, and thrombolysis in myocardial infarction. Next slide, please. So I'll just show you a couple of cases. So this was a 58-year-old gentleman. He had undergone a bypass, and whilst he was still in hospital, he noted a sudden paralysis of the left side at 7:30 a.m. in the morning. MRI was not possible because he had those wires in the chest, sternal wires. So CT scan was done. Next, please. So the CT scan shows, next please, that the artery is totally occluded. You see on the left side, you can see the nice artery. On the right side, corresponding artery is missing completely. There is no artery on the right side at all. No artery on the right side at all. On the left side, you can see a nice artery inside the head and in the neck. Next. Next. And when this is an angiogram. This is what we do now. This is a cerebral angiogram, and you can see there is one artery which has got branches. That is the one which supplies the neck, the muscle, the bone, etc. The one which is with a thin artery which is going straight up is the brain artery. There are no branches in the neck and the brain artery. And if you look at the side image, it is totally blocked. There is no flow beyond. So on the left, we call it subtracted angiography. On the right, it is non-subtracted. You can see the skull at the back. On the left side, you don't see the skull at all. You just see the artery. This is a great thing. This is called subtraction angiography. And we always work subtracted. We can see what we are doing. With that skull, we are obscured by what we want to see. We don't see very well. Next, please. So here you can see we have completely opened the artery. It's a wonder. In 10 minutes, literally in this patient, in 10 minutes, we had restored blood flow. Literally from groin to recanalization was 10 minutes. Next. And see the patient. The patient had a complete, next. Okay. We can forget about that one. But this is the stent. You see that stent? You can see the clot inside that stent. It is like a wire mesh. It is like a jali. So the stent has clots inside it. This stent is called a solitaire, but there are several more on the market. After 2015, up to 2015, companies did not spend any money on research for stroke, ischemic stroke. They were spending on hemorrhage stroke. After 2015, every company wants to make a new device. They want to show some difference on how we will be able to reopen the arteries in 5 minutes instead of 10 minutes and things like that. So this is one of the older ones. This is called a solitaire, but it is still the best. I like this one. Next. Next, please. Oh, this one is also not working. So this was to show that the patient has recovered completely. He is completely normal. 4 hours later, he is walking. This is the kind of result we get. Patient paralyzed. This is another lady. The first CT scan is almost normal, but she has a paralysis. This is on the right side of the brain. So the CT was normal. The first image on the left is the CT scan. So they went to a small hospital. Somebody gave the patient the injection to, to, to do the thrombolysis, but it didn't work. So they sent the patient to us. We did an immediate MRI. We saw that the infarct was fairly large, and on the lower film there is no artery on the right side, and you see that clump, that it's like a rock. What we pulled out was like a rock. There is no way the artery could have opened with injection alone. And this patient also, next this patient was completely paralyzed again. Next slide, please. Oh no, it's not okay. So this patient also made a complete recovery. This was a video to show the patient walking, a patient who had complete paralysis. So if we are in time, if we are, we also have to hurry. Like if I get a patient with stroke, I get the everything done as quickly as possible in the hospital. I have to run after it. I have juniors now, I have fellows now who do the running, but somebody has to pursue, make sure that we get things done. Otherwise, I have patients who tell me, Doctor, I had reached the hospital, but they wasted time there. That is our responsibility. We should see to it that we don't allow it to happen. And from the hospital, stroke patient is coming, so that he is not kept waiting outside. Or even in a doctor's clinic, if a patient is going to a doctor, we should inform the patient that stroke patient is coming. Please take me first. Drop everything else. That's what we do. Even for MRI, if a patient is on an MRI table, as soon as that part is done, we take the patient off. We put the stroke patient on, complete the MRI, and then put the old patient back again to complete his study. So that is how it should be done. Because if a patient recovers, then um, it is so rewarding. I've had patients completely paralyzed, completely normal 2 hours later, no speech, both hands, both legs paralyzed. Next morning they are walking. It is such a rewarding thing. But unfortunately for us, the numbers that we do are abysmally small. Of course, patients have to spend. That stent I showed you costs about 2 lakh rupees. The suction device costs about 3 to 4 lakh rupees. But remember, the patient is spending on day one. Subsequently, he's not spending any money. He's normal. He's generating income again. But if a patient remains paralyzed for the rest of his life, he is going to be dependent, and the family has to spend the other way. So initially, it may appear as if patients say, "अरे हम hospital में 2 दिन थे 5 लाख खर्चा हो गया." But the patient's recovery is so good most of the time. Rarely, of course, you can get a complication, and that is the thing. So, may I continue or should I stop now? Because if you want, I can stop.
I think so.
You can go for questions now.
But yes, I
I will
will
just no.
I think
Let me go to the last slide. Let me go to the last slide.
Yes, please. Yes, please.
Go straight to the last slide. Before, thank you. So prevention of stroke. Mr. Ranganathan had said prevention. We can do nothing about our non-modifiable risk factors. As we grow older, we are going to be at risk of stroke. Age, sex. The males are protected. The females are protected until menopause. As long as they are getting their periods, the monthly periods, they are protected. Once their periods stop, they are as vulnerable as the males. But they are protected, but not completely. A young woman may still get a stroke. The youngest woman that I have treated with a stroke was a 25-year-old. So don't think that because I am female, I am young, I won't get a stroke. You have to observe the precautions every time. So there are some non-modifiable, which is sex, age, and heredity. If there is in your family there is a history of stroke, the chance of your getting a stroke is very high. And there are modifiable risk factors. So what are they? Hypertension. You must control your blood pressure. Diabetes. In fact, diabetes is very important. Smoking. Smoking is worst. It is bad for arteries and all arteries. Arteries of the heart, arteries of the brain, arteries of the kidney, arteries of the hands and legs. We have patients, and most of our patients who come to us with stroke, or I didn't talk about the other thing that we do to prevent these things or investigations because there was no time. But still, smoking, I say tobacco in any form, whether it is chewing, whether it's smoking, you don't see anyone using tapkir anymore, the snuff anymore, but tobacco in any form. A lot of people use it for brushing their teeth, in the villages especially. That's bad. Atrial fibrillation is something which the cardiologists treat. And I have seen many patients where they have atrial fibrillation. For some strange reason, the physicians have not started anticoagulation and they come with a stroke. So, if there is atrial fibrillation, the patient must be given blood thinners, anticoagulant. And a lot of us are vegetarians. So, amongst vegetarians, the B12, vitamin B12 is low, homocysteine is high. This is one of the causes of stroke as well as heart attack, of course. And if a patient has had a TIA earlier, he must be investigated to find out why he got the TIA so that he doesn't get a new stroke again. In about 50% of patients, something will be found and a stroke, major stroke, can then be prevented. So we have to be careful about the modifiable risk factors. Non-modifiable, of course, you cannot do anything about. Thank you very much for your attention. But I think I have done an incomplete job. I would have liked to show you what we can do if a patient recovers, but that we can do another time.
Yes, but there was a particular one which you had to bring out. Be fast. Would you like to just enlighten us on that one?
Oh yes. Oh yes.
Yes,
Can we go back to the slide? Can we go back to the slide?
And also, there are many questions which have come, and you have addressed it in your presentation already. However, the one, I think it is just before your thank you, if I'm not mistaken.
Go up two slides above.
Can we
go up, go back? Go back on the slide. One more. Yeah. Can you make this full screen? No. Down. Down, next one.
No, the next one.
Yeah. So this is Be Fast. FAST has been an acronym for many years. FAST, that meant face, arm, speech, and time. I mentioned to you, time is very important for us. So there is a droop of the face. Patient is speaking and becomes slurred. So that is face. Arm, the arm droops. I told you they are shaving their top of their arm. Speech, if he is left-handed, the stroke is on the left side. If he is right-handed, stroke is on the left side, the speech will be affected. Or time. But this is to which we have added two more, balance and eyes. Balance is for posterior circulation. FAST is essentially for anterior circulation, carotid circulation. Balance, if there is a stroke in the posterior circulation, the vertebropatellar tree, the brainstem, cerebellum, there is a loss of balance. Patient feels that he's staggering, he goes to one side or the other, he's not able to see, he sees double. So eyes is not only blurred vision, but it can be double vision. It can be vision which is unsteady, moving like that constantly. So if any of these things are there, balance, eyes, face, arm, speech, any of these are affected, one should rush to a hospital where CTA or MRA can be done and treatment can be started. Don't go to a standalone center. Let me repeat it again. And ask for a CTA or MRA, not CT or MRI, MR angiography. May I add one more thing? Again, I've seen strange thing. In Mumbai, when we ask for an MRA, MR angiography, we get the brain. I showed you those images of the brain, and we also see the artery. But in Mumbai, we see the arteries right from where they start from the heart up to the last tiny branch in the brain. In Ahmedabad, for instance, they look at the brain, they look at the arteries, but only inside the head. They don't look at the neck arteries. In Pune, I had a patient last week. They only looked at the arteries, they didn't look at the brain. So it doesn't make sense. When you say an MRA, it should be a complete MRA, and that MRA should include the brain, it should include the head arteries and the neck arteries. So this is my plea to radiologists, if there are any listening to us, or to do a complete MRA, and if you have a stroke protocol in place, even on a 1.5 Tesla machine, it can be done in 13 minutes. On the faster, newer machines, the 3 Tesla, it may be done in even shorter time. Thank you.
Thank you, Doctor. I think I was just looking at the questions that have already come to us. And I think so many of them you have already addressed in your presentation. So what we will do is those questions, your answers, we will have it published in when we put up the report. But there was a question which came in, uh, which had to do with lifestyle changes. So if you can have that question on the screen, please. It is a WhatsApp question which talks about what are the lifestyle changes required to prevent brain stroke and which people are more susceptible to it. What are the precautions to be taken to avoid a second attack? Now, I think some you have already addressed. Now, would you like to add something to it?
Yeah, one is I didn't mention was exercise and obesity.
Hmm.
We have become sedentary. We live a sedentary lifestyle. We are not active anymore. We drive to our work in a car. We take a lift to go up. We don't use the stairs, and we have all these unhealthy foodstuffs that we eat. All the processed foods. All of them are bad. So
So
we
true.
should stick to healthy, natural fiber diet. And I don't believe in any of these fads which you have from time to time. You have somebody with the vegetarian diet and then you have something else. I think what is important is to eat a balanced diet where you have a right proportion of everything. A common question about alcohol. Alcohol, they
Yes.
say, some say helps, some say it doesn't help. Some will say that the wine industry wants to promote red wine. That's why they are pushing for it. Like dark chocolate is supposed to prevent heart attack. So whatever should be in moderation. But activity, physical activity is the most important thing. So all of us with our sedentary lifestyle, with our busy lifestyle, we are trying to, it's like a dog trying to catch its tail. We are just going around and around in circles, but not doing enough physical exercise. So I can give you my personal example. I 1977, one of my colleagues said, "Why don't you come and play badminton? You play very well." I said, "Who'll get up in the morning?" He said, "Don't worry, I'll come and wake you up." So he used to come and wake me up for 3 months. He used to wait for me to get ready. But now it's a habit. I get up at 5 o'clock every day, no matter what time we go to bed. And the first thing in the morning is we have a cup of tea and then we do something. Now with the COVID and all that, we were walking within our compound. Now I go to the sea face, I walk. I used to play badminton, multiple injuries. I've had multiple injuries, but I didn't stop. So the important thing is be regular. I have seen patients or people, let's say, not patients, people, they come, they'll be there for 1 month, 2 months, very enthusiastic, and then gradually the enthusiasm wanes and they disappear. So one should be persistent. Don't give up. And at least 5 days of the week, one should, and don't say where I'm busy. You find time for yourself, morning, evening, night, whenever. This is another thing I learned. In India, we say go early in the morning, early bird catches the worm, but not necessarily. You can go anytime, whenever you have time. So in Europe, I've seen people go for jogging after they have come back from their place of work, or they jog home. Don't use the lift, use staircase, and as far as possible, especially to go up. Coming down, you may use the lift, but going up, use the other way around. A lot of people use the so use the lift to come down because it is bad on the knees. If you have to come down 5 floors every day, coming down is bad on the knees, but going up is good for the heart and for the brain. And main thing is the diet. And as I said, if one has atrial fibrillation, and this the cardiologist will diagnose, there'll be an irregular beat of the heart. Atrial fibrillation means the heart rhythm is not regular; it is irregular. A previous TI, smoking, diabetes. These are things, and lipids. I did mention lipids, cholesterol, especially the LDL and triglycerides. Amongst Indians, triglycerides is also high quite often. In my family, for instance, triglycerides is high. It's a familial trait, so we have to manage it. And the other is LDL. LDL is also, again, that is the bad cholesterol. So these are things we have to do.
There was a question
No
now being
smoking.
COVID. Yes, of course. There is a lot of similarity between what you have just mentioned with this question and the session we had with Dr. Parajani regarding heart attacks, the hidden epidemic which we had on the 13th. So there is a lot of correlation between the two. It is no wonder heart and brain ought to be on the same platform somewhere along. In COVID times, in COVID times, the question which has come in, is COVID a factor for strokes? And
Yes,
in COVID
COVID.
time, yes, and how can one ensure hospitalization of a patient with a stroke at this time? I think that's one of the biggest challenge and biggest fear that people will have now, or have now already.
So,
Could we have
so
the question on the screen, please?
one of my colleagues analyzed his cases of stroke, and they, in fact, are publishing it. They looked at 100 cases of stroke in these COVID times, and only in patients who had COVID. So what was surprising and different from the findings of, for instance, the Chinese or the American was that stroke of their 100 patients, ischemic stroke, loss of blood supply, ischemic stroke occurred in 87%. In 13, there was blockage of the brain veins, and in 9, there was hemorrhage into the brain. Only in 9 there was hemorrhage into the brain. And in the Western literature and Chinese literature, only those who had severe COVID disease had stroke. But in fact, of my colleague's cases, of the 87 that he has seen, 67% presented with stroke. Their presentation was with stroke. Their symptoms of COVID were so mild that they had been ignored. They didn't realize they had cough, they had fever, they had all that. Maybe they didn't have it and they came with a stroke. So, why does stroke occur? Stroke occurs principally because there is something called the autoimmune response. The body recognizes the person, but when there is this response, the body does not recognize its own body, its own different parts. So it treats it as a foreign body and tries to, so for instance, in the lungs, so we call it thrombosis. The blood vessels get blocked, they get thrombosed. And this happens in the lungs, it happens in the brain. And it was not realized that this is happening in the brain, but there are a large number of patients. So most of them are acute ischemic. And large vessel occlusion also occurs because there is thrombosis of the veins as well as arteries, but arteries more than veins. About getting a bed in the, so if there is a stroke again, the problem today is hospitals are chary of admitting a patient without first testing. But if it is an acute stroke, like of these 100, I think 17 or 18 patients underwent intravenous thrombolysis, and only one patient underwent thrombectomy. Only one patient was the clot load. Or one reason is for the patient to get to the hospital in time, and so you have to convince the hospital that you get the patient in, do the take all. So what we have to do is take all the precautions. When the patient comes to the casualty, the the entire casualty staff has to wear PPE, the personal protective equipment. Be very careful not to expose themselves. Patient goes to CT scan. Now the patients, we have the ancillary staff. We have the nurses, we have the ward boys, we have the dresser. So everyone has to take the same precaution. Patient goes to CT scan. So you have to make sure that the CT scan has been properly cleaned, and when the patient goes on, when the patient goes off also. So all these precautions have to be taken. So what is typically done is you assume that patient who comes is COVID positive. We as doctors take all the precautions that we can. We go ahead and do whatever needs to be done. Post procedure, yeah. One more thing that is done now is in many places, if a patient is likely to need an intervention, the patient's anesthesia, intubation, we call it intubation, is started right in the casualty because that is already a potentially infected area or contaminated area. Let's not say infected area, contaminated area. So the intubation is done in the casualty, then the patient is shifted everywhere. And again, when the patient is extubated, when the tube is taken out, that is another time when he can cause infection. So that again is done in a different isolated area. It's not done in the cath lab. Intubation is not done in the cath lab. We do it outside in another area so that we do not contaminate the whole general ward, general hospital. So every precaution is taken until such time as a report comes in. And it's not only the COVID RT-PCR or the antigen. What we also look at are some of the blood parameters. So the blood and the chest CT. The chest CT is very important because even with a minor infection, the chest CT shows some changes. And the blood tests are, if you wanted to know, interleukin 6, ferritin, and D-dimer. These are the three, and CRP. These are the four important tests which are done for all these patients. And we follow up on these tests also. So all these patients who had stroke, in all of them, all these parameters were high.
So the question, so the one point here is, doctor, so you think that COVID is something which can cause strokes or the other way around? So, because I think
It's
most
not
people
the,
in this time is very keen
yeah, actually, it
to
is the COVID
understand.
which is causing. It is the COVID, but it is not the organism. It is the response of the body to the COVID which is causing the stroke. So it's a difficult concept, but it is the COVID triggers this response in the body,
It does do.
and
In some cases,
so
it
all
does
these
trigger with that.
we call that a we call that a cytokine storm. So when that cytokine storm occurs, usually it occurs around day 10, day 12 of the infection, not on day 1, day 2, day 3. It occurs usually around, and by then the patient in fact is very well. So the patient has the infection on
Ah,
day 1, day 2, day
that's
3,
interesting.
day 5, day 6. He is not well. He has fever. He may have loose motion. He may have cough, and then he's normal. He's good. And suddenly, out of the blue, on day 10, everything
Hmm.
goes away. So the heart packs up, the kidneys back up. It's a multi-organ involvement. It's not only the brain. Many times it is only the brain, but it can be multi-organ. It can be the brain, the kidney, the heart, even skin. The blood vessels supplying the skin, they get mottled blotches on the skin as well. So there is no part of the body which is spared. It is purely the patient's autoimmune response, and everybody's autoimmune response. So when they give steroids. You must have read about steroids. Everyone must have read about
Yes, yes.
dexamethasone is the steroid which is given, or
Hmm.
hydrocortisone. So that is given to prevent this autoimmune response or to prevent the cytokine storm. So steroids are more than
So,
remdesivir.
we have,
Steroids is a major part of treatment. Sorry.
I see. Now, we have crossed our time, and we are already 15 minutes beyond our time. So what I'm going to do is, there are a few questions which are similar, and I will be sending all the questions, Doctor, like the case studies that I had done. There is one question though, which is very interesting, and I'd like to just quickly bring it your notice, is that wireless radiation, such as 5G, does it have any consequence leading to brain stroke? Because now with technology and 5G very much talked about, is there a correlation? Then I would like to take up a few questions, at least let me see on Facebook. I'm sure there were questions over there.
I really don't know the answer to the 5G, and we really don't know, because
Okay,
one
let
thing
me
is for
leave it
sure: the
as,
old phones. If you are using an earphone, it is safer.
yeah.
If you keep the phone close to your ear, patients come, especially nowadays, these boys and girls, they use the phone for. I had somebody coming and saying, "Oh, I use the phone for at least 8 hours every day." What the hell is it doing for 8 hours every day with the phone? But you can imagine the amount of radiation the brain is getting. So these patients, these children come with brain tumors after 2 years, 3 years of use for 8 hours and 10 hours. So using a remote is safer in that sense.
So
Use a
the
cordless or whatever.
earplugs, yeah,
Yeah,
okay,
whatever.
right.
Bluetooth,
Um,
Bluetooth.
let's see if there, can we take up a question? Have questions come on Facebook or YouTube?
Uh,
This is more to the
Aspirin
heart
a day.
attack.
Yeah. No, that's a aspirin can keep an ischemic stroke away, but it can cause hemorrhage also. So we have some patients who come with the brain studded with small areas of hemorrhage. So I don't think it is right to give it to everybody. It should be given only to patients who are at risk. So who are the patients at risk? Those who are smokers, those who are diabetics, those who have high cholesterol or the LDL high, and heredity. Don't give it to everybody. I discourage that. Unless there is some reason for it, don't give it. Because There is nothing without side effects, nothing without toxicity. So, if required, certainly. Even this is true for the anti-statin, the rosuvastatin or atorvastatin. Unless the lipids are high, don't give it. Or if the patient is, unless the patient is very obese or patient has diabetes, we don't give atorvastatin. It has a side effect on the liver. So it should be given in small dose if required, or high dose if required. Depending on if it is an acute thing, then we give high dose also. We give up to 80 milligrams. Otherwise, we give 10 milligrams. So
There is a
aspirin is not
question,
necessary.
right. There's a question which came in. How important is the role of mental health when it comes to brain attacks or strokes? Can it predict
No,
a
the
brain attack or
mental health has nothing to do with stroke. A
right?
stroke is a
So
physical
that
structure which
answer.
goes in. Mental health is something which is not structure, it is function. Stroke is because of something structural, a clot going up, an artery getting
Mm,
torn, dissection we call it, or
mm,
rupture of an artery. But the structure of the brain gets affected, not the function. Function is secondarily affected because the blood supply is
mhm,
low. So one more thing, if there is an infarct, there is no recovery. But in a hemorrhage, hematoma, there is a big clot in the brain, in the head, in the brain. The brain there is compressed. The brain is not injured. So the brain recovers very well. But in an infarct, the brain is dead. That those parts of the brain are dead. They don't recover. So the
I see.
prognosis, we call it
Uh,
prognosis, the future is better for a hematoma
right.
than it is for an infarct.
Have there any questions come on YouTube that we could take up just now, or else if it comes later, then I'll share with you, of course, Doctor. Uh,
I have time,
I'm
so I
sure
have
that
no
there will
problem. Whatever.
no, but we can't cross too long,
I
and
know.
our
I
viewers would
know.
be quite wondering that because many questions have already been answered, so I would not like to take them up. Now, this question has come in. Oh, this is very interesting. This is on
This cannot.
Facebook. How do you detect
There is no
cytokine?
way. Yeah, cytokine storm. There is no fire. There is no indicator. It is always sudden. And in fact, sometimes it is what we call retrospective. You look at, you
Right.
analyze what happened, and oh, this is what. Because usually when a cytokine storm strikes, it is like a lightning
Mm.
strike. It injures many organs. So patient may come in with a heart attack, a major heart attack, have a kidney shutdown, and almost within minutes die. So cytokine storm is like it's a huge release of various hormones and drugs. We can't
There
predict.
are quite a few people who have written to us with their own case studies, with their own cases. Obviously, on this platform, we will not be able to highlight those directly, but I will be sending those three you have already answered. I will be sending the answers to them. A couple of more have come, Doctor. So I would request your indulgence to give your general opinion
Sure,
to those questions. Yes.
sure.
I'm
Yes.
sure that there will be other questions which will come in through the which we will highlight, and I'll compile all of the questions and send to you. Um, Let me ask you one other, which also has been
May 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 I say some one word or two? Uh,
yes,
the
yes,
government the government of India is seized
yes,
with this terrible what we call it epidemic of stroke, not unrelated to COVID. So in fact, during the world, the Indians, we have a Indian Stroke Organization, Indian Stroke Association. So in the World
yes,
Day program tomorrow, uh, the health minister himself will be releasing making some statements, major policy statements about what they will do for stroke. Already the government is doing its bit. They are supporting the injection, like I told you, it is 50,000
yes,
rupees, the intravenous thrombolysis. But now the government is paying for it. So formally, the civil hospitals, the government hospitals did not have this in stock. But now most government hospitals are supposed to have them, and it should be dispensed free. So at least the intravenous thrombolysis can be done. Thrombectomy, as of now, Government is supporting through all those various schemes, the other schemes, but the limit there is 1.5 to 2 lakhs. The stent itself costs 2 lakhs. So in private hospital, it is impossible because the patient has to go to the ICU. Every patient has to go to the ICU. He has to have imaging. We have to do a CT scan. All that adds to the cost. So we have to do something about the cost of treatment. The immediate cost is high, but the long-term cost is much lower if the patient recovers, which today is in
Okay.
70% of our patients.
Uh-huh. So then in that case, our hospital system and healthcare on this front. So tomorrow we will look forward to what the ministry does announce, and then take on and which campaign we can do as an organization. We will be looking at it tomorrow being World Day. It can happen suddenly, as you have said and emphasized in your talk. So we should all be prepared and not be taken unaware, though it will happen suddenly, as you said. Is it true that 1 in every 4 persons is at risk of a stroke?
No, the risk is much smaller. See, first thing is if a person gets COVID, 95% patients do very well. They have no problem. Of the 5% who have a problem, very, very infinitesimal small number will have stroke. Because we are not talking about hundreds of thousands of patients. So the
Mhm.
number of patients getting stroke is not very high, but it can happen.
But that's true with COVID. But in general terms,
In
is
general
it
terms,
is
yes, because lifestyle, like I told you, as we grow older, as our life expectancy increases,
hmm.
the risk of stroke is that much higher. 7 per 1,000. That's the figure that I showed for up to age of 65. 7 per 1,000. That is 7 per 10,000. But that's even so, that's a huge number.
So that brings us to another question. That suppose for a bystander, for example, what should a bystander do if they see someone is having a stroke? And because the common symptoms, people are more attuned towards the heart attack, and there are a lot of people who will not figure out that heart attack between heart attack and stroke. It's a very common you know uh, misunderstanding. How do we deal with this?
See, you can't do. You can't do anything. You have to just make sure that the patient is breathing well, his tongue is not falling back, he is not drowning in his own secretions. That's all that you can do. And have the patient shifted to a hospital. Like I told you, you have to have some form of imaging. You have to have a CT, you have to have an MR, something has to be done. And ideally, go to a hospital where all this can be done and the subsequent treatment also can be offered. All that can be done is not do complete CPR, but at least make sure that the airway remains open and the patient does not hurt himself. If he's getting a convulsion, if he's falling down, protect him so that he doesn't hurt himself, doesn't bite his tongue. That's all. Acute
Doctor,
stroke, you can't do anything. You have to go to a hospital.
right now that brings us to
So
convergence, which is
one more thing, especially for the older citizens, you should have
hmm,
some form of identity card on your person whenever you are alone, so that if with a phone number which can be contacted, any senior
right.
person should have some form of identity card or phone number with him, so that if something happens, bystanders can call for help.
Right.
Inform the family. Inform the family.
Absolutely. And I think that is not only for older senior citizens, but generally, as a general practice, anything can happen at any time. When you mentioned about convulsions, now, convulsions can be due to various reasons. So, one of the things I would request you, doctor, between, from the point of view of a brain stroke or otherwise, what are the few key things that we as an organization could have, which we can give to the public as uh, like a first aid, like to understand, to recognize, because in epilepsy also you have convulsions. So therefore, layperson will not be able to differentiate. So the key factors which you would tell us, and we could publicize that, which would enable people, I mean, if you're at home, it's one thing. So generally for lay people, how they can help uh, to take, the first steps towards taking the person to hospital. So this is something which I will want you to do. We may not take it up right now because we are quite beyond our time, but this is something which will have to be an ongoing that guidance that we will need from you. So, Dr. Karapurkar, you're going to be with us because awareness about strokes is not really that common. So, therefore, we need to make a lot more effort to take it to the public. A lot of people know about heart attacks, is very common, and symptoms are sometimes, they overlap, so to speak. So, how to recognize whatever guidance you may give us. So, as we speak,
and also we've covered only a part of acute stroke. We've
I
not
know.
talked about prevention.
Yes. Yeah, could you
We've not talked about hemorrhagic stroke at all. We've not talked about hemorrhagic stroke at all.
Right, but that's a long session. But for preventive side, if there are some things that you would like to say in conclusion, so to speak, because we will have to close the session, even though I'm still receiving questions, and I will invite the viewers that questions, some are answered, whole lot will go to Dr. Karapurkar. So I would request that you come back to see our report where we will have it published. That's a certainty. So do tell us about the preventive,
The preventive aspect is, so if you've had a TIA, always investigate why you got the TIA, what produced the transient ischemic attack, which means that we need to do a 2D echo, we need to do, of course, an ECG, we need to do a 2D echo to see whether a clot has gone up from the heart. Sometimes the 2D echo also is normal. Then we do something called TEE, transesophageal echo. That is again to see whether a clot has gone from the heart. And we do a Holter, where we stick a electrode onto the chest and give the electrode, the sensor to the family. The patient records. Earlier we were doing for 24 hours, then we extended to 48 hours, and now we say for 3 weeks. And we record any event. It is called an event of abnormal beating of the heart or a clot inside, which can cause stroke. So that is one aspect. And second is, of course, like we said, change of lifestyle. That is the most important. Regular weight exercise, avoid obesity, eat healthy, and no smoking. Control of diabetes, control of blood pressure.
And keep smiling. I think when we talked about mental health, because in COVID times, I think there is a huge amount of fatigue and lethargy that has been with all of us, with uncertain times, etc. So having a positive outlook, even with these challenging times, is a task. I think we all should strive for that. Dr. Karapurkar, it is a great privilege to have had you. I know we could go on for a break of a while. We will have another session on the other aspect of strokes. And in the meantime, I will be sending you questions for you to answer. Your videos, your presentation, all are going to be uploaded with the report. So I request all viewers, do spread the word and do come back and see this properly, with time. And after seeing the PPT later, should you have questions, free to give us. I will on pass to you, Dr. Karapurkar. In normal times, if you are face-to-face, as in a gathering, at this point of time, whilst we close the session, we would be presenting you with a memento. Right now, we have to suffice with a virtual memento. So on behalf of the trustees of VCAN, may I virtually present this memento in appreciation for being with us this evening. And thank you warmly for spending so much time with us. I once again thank our support partner, the British Candy Hospital Trust, and our young team of volunteers, the Student Council, the students of Gen College, our college partner, Team Technology, of course, viewers, members of the media, and everyone. So with that note, I would wish good night to all. And Dr. Karapurkar, I will be in touch with you. Thank you once again for being with us.
Thank you so much. was my pleasure.
Thank you for